All right. Well, I'm so glad you guys could find your way out here. We could spend the day together here.
Yeah,
thanks for having us.
It's great catching up, Steve. I get to see a lot of you, and Justin, I've seen you
Little less,
over the
but
years,
yeah.
but yeah, in meetings and stuff. But they're really thrilled. I mean, to have two great ODs like yourself, and I know we've chatted about a bunch of stuff already, but myopia and frankly the epidemic and what's happening out there. I'd love to just chat a little bit and get insights about what's going on out there and how Cooper and IDOC and MiSight can make a big difference out there. So Justin, maybe take us through a little bit of what's going on out there right now.
Gosh, I feel like what I get exposed to in myopia, it's every day, but I forget what the day-to-day OD gets to see that, or doesn't see, what I actually see myself. And the last 4.5 years being full-time with CooperVision has definitely flown by, and we've grown tremendously as a team of 3 full-time ODs now, and we recently increased from 10 myopia sales team members up to 25. So we really are kind of doubling down and taking myopia head on because in my estimation at least, there's still millions more children that need treatment and that are not getting it today. So try to look at it like glass half full and provide that opportunity to every single OD out there. Yeah.
Just you said there's millions of kids out there that still need help. Can you maybe add some context to that? How big is the problem? Because I suspect that a lot of the population isn't aware of that, or maybe doesn't even perceive it as a disease. And I suspect that there's even a lot of people within the OD community that aren't aware how big the problem is. Can you put some context to that?
Yeah, so a few years back, I did a ARVO poster, a scientific poster, with an ophthalmologist, and we, at the time, were taking the 2020 census data throughout the whole U.S., and using some evidence from the scientific literature. For instance, we know myopia is less prevalent in rural communities versus urban communities. We came up with the number of 19.5 million children. Now, children age 5 to 17. So of the 19.5 million children with myopia, I don't think maybe 500,000 don't need treatment. So let's just call it 19 million for a nice round number. Yeah.
I saw somewhere that you said the goal was to get kids graduating under -3.
Correct. Yeah.
How do we get there? I mean, what? So maybe a 2-part question here. I'm curious, what has changed over the last, let's say, 5 years in terms of myopia management, and also what has to happen for us to get to that point where we're hitting those goals?
Yeah, I think those that we touch base with, a lot of their tweens and teenagers are already -5 and -6, and it's not too late. But the ideal situation is to start treating them when they're -1. And there's nothing super magical about -3, but beyond that is where that risk of myopic maculopathy starts to skyrocket. So we want to minimize the chance of that happening as much as possible. But even today, I think a lot of doctors, to no fault of their own, they're just naturally inclined to be like, let's just wait to see if they get worse. And if they do get worse by a lot, then that warrants treatment rather than treating if there's any myopia at all. Because, growing kids, they get worse. So it's not kind of like a if, but when.
No, I love that point because, we get a chance to meet and talk to a lot of IDOC members and ODs, and myopia often comes up. But I hear, as you just said, I'll get to that, or I'm thinking about it. So, how do we get not just our members, but all of optometry to really get behind this? Because the prevention is what's really, really critical.
Yeah. It's that ounce of prevention is worth a pound of cure. And myopia has been called like a public health threat. And is that like hyperbole? I don't quite think so. I think we're living into that reality. If maybe we go visit some retinal specialists, we'll find a ton of myopic maculopathy. They just maybe don't happen to come into our optometric practices at these patients that are now in their 40s, 50s, and 60s. And I think the really sad part about myopic maculopathy, it does happen when we're younger, in our late 40s or early 50s. This is not the macular degeneration that hits in our 70s. So as example of myself, I'm a -10, and I got a posterior vitreous detachment when I was 36 years old. Thankfully, it didn't take any retina with it, but that is the reality of many, I guess, middle-aged young adults like myself living with high myopia.
Yeah.
Middle-aged.
Yeah. I'm graduating myself.
Me. I don't know where that puts me at.
Let's not go there.
But you're okay. I'll in between there somewhere. You have a story.
Yeah.
I'm just curious. A lot of the doctors that I talk to seem to have their own story in terms of myopia management, whether it's high prescription that they grew up with, or they know somebody, or they're worried about their kids. Do you find that drives a lot of their decision to go into that specialty? I've always found in general, in terms of specialty, doctors that gravitate toward that route tend to have something in their past that motivated them to want to do that.
I agree, Steve. I mean, I used to teach optometry school, and no joke, there'd be always one or two people in every class that had strabismus themselves, and that's what brought them into optometry. And I think myopia is the most prevalent disease we'll treat in our careers, and that kind of motivates folks to dive into this and really kind of start earlier than maybe most would, because there isn't that lived experience from their childhood onwards, if you will. Yeah.
We talk a lot about specialties, and I know you do that as well, Steve, when you talk to our members. This one seems like such a sweet spot to me, right? Because most optometrists have great experience with contact lenses.
Yeah.
IDOC members and CooperVision do tremendous work together, and we've been able to have a new program to help the doctors with ways to bring MiSight in and CRT and some other things. But this specialty seems great, not just for the prevalence, but how a doctor understands contact lenses and can put this into the mix.
Yeah.
So maybe talk a little bit about how a doctor could put this into the mix and start to really get behind MiSight and myopia management.
Yeah, and I think, Dave, it comes back to what you said earlier, like what's changed or evolved over the years, because when we first launched in 2020, it was very much still like a specialty, and we needed to make sure, and we still do, that's a treatment program. People should take it seriously. It elevates like what we can do for families living in the community where the practice is. But with MiSight's FDA approval and all this scientific rigor of the 7-year study, it is kind of the easy button. People have said that before, because it really doesn't take extra time per se compared to a daily disposable, but it's just a very strong and simple tool in the toolbox while having other ways to also treat with myopia management. But I think people definitely make it more complicated in their head. and that kind of gets in the way because they don't feel like all their ducks are lined up in a row as they kind of start, and then they stop, and then they kind of start, and then they give up. And that's very human nature, right? Like, we want to be able to encourage them to keep going, because it's not different than dry eye. I remember talking to like 12 adult patients, like, you need this dry eye treatment, and I'd only have 2 out of the 12 sign up. And we can't like take that personally per se, and we need to just keep educating about the importance. Yeah.
From a change standpoint, I've talked with enough ODs that introducing change into a current model is a struggle for a lot of them. Sometimes that's staff resistance, sometimes it's efficiency, time management, those sorts of things. Dave, I'm interested in your perspective on this as well. From a leadership standpoint, introducing change, any advice for doctors out there that have a certain way they've been doing things for years, and now a new service comes along that they'd have to implement into the practice? How would they navigate some of the challenges, real or perceived, that go into implementing something new?
Yeah. Look, change is hard. I think what's great, Justin, that you and the entire team at Cooper have made sort of the science easy, you've made the product easy, but the hard part becomes almost within the practice and talking to the patients. And I know we'll get into that a little bit, because that fascinates me as well, talking to the parents really, right, as much as the kid. But you know, I know you talked to a couple doctors, Dr. Guth, Dr. Tybone, and they had some really good information about this. I loved some of the tips that they had. So they said training the staff was very important, right? So helping the staff understand. But it's almost the why. It starts with the why. Why is our practice going to get behind myopia management? What's the reason? And sure, it can be because it's a specialty, but the reality is you're changing people's lives for the long run. You have the opportunity to prevent something, change a person's life at a very young age. And so training is very important. I loved what I think Dr. Guth said. I wanted to find people on my staff who love kids, who want to work with kids, right? And so then you have that passion. And I think the last thing is share the success stories. When you start having success,
Yes.
attribute it to the staff, attribute it to everybody as a team making this happen. And I'm sure you can share the testimonials you get when all of a sudden the myopia is not progressing as it has been. So, but I think it starts with, why are we doing this, so that people understand why we're doing it, and then you get into some of the other nuts and bolts.
Yeah, and sometimes the staff do have children themselves that could be your first patients for myopia control,
Right, yeah.
and that definitely helps solidify, like you said, the wins every 6 months, and you get to celebrate that, and especially when you have context of the fast progression before treatment, and now you see 0 diopters of change, it gets really rewarding and gratifying.
Yeah.
And operationally, it's not that time consuming, correct?
Right,
To implement that as opposed to some other specialties, if that's a concern of the staff.
Yeah, people always like ask me, those optical biometers to measure axial length are so darn expensive. At the same time, I'm like, you have wide field retinal imaging that takes 2,300 patients to pay off, or an OCT that similarly at $39 a click, it's going to take a long time to pay off, and there's no upfront cost with myopia. Once you do buy an axial length, it'll take about 33 patients to pay off. So I think it's important to put that into context and kind of maybe help ODs and their staff plan out that future. Like how little does it take to get started, and where can we work towards in your growth journey?
Yeah, I think that future orientation is important, Steve. I know you do a lot of coaching and teaching about vision and business plans and thinking long term. What's hard about this is you don't get an instant sort of fix, right?
Yeah, like you do with single vision correction.
Yeah. So what are the techniques to sort of help? And I think it's planning, right? But it's also, one of the doctors was saying, I even start talking about this conversation when the patient maybe is 6, then they're back in when they're 7, and then by the time they're 8, I've already see what's happening. But then you have to almost get a year or 2 or 3 down the road. So what are the ways to help practices be patient, I guess, with the patients?
Yeah, gosh, I mean, definitely what you said is true. Like, not enough 6-year-olds are getting eye exams in general, let alone the myopia conversation. So every chance, like, the staff needs to be scheduling children of adult patients. You have a 8-year-old, you need to really get those younger siblings scheduled in as well, just so you can baseline and see what their growth pattern is, if you will, and assess those risk factors. So I think it starts with either incentivizing staff to get the kids of the adult patients, or just to start measuring how many kids a week am I seeing right now compared to last year same time, and what can we hope to get to in order to serve all the children in our community.
The conversation is not completely unique to myopia management, but it's unique in the sense that it's not often the patient we're having the discussion with 8, 9-year-old Jimmy in the chair, but it's mom or dad sitting over there in the corner where you have to turn and explain it to them, and you have to get their buy-in. Now, I'm curious, 2 different perspectives. I got an OD who's very familiar with OD. You're a parent. So I'm curious your visceral reaction, maybe from an outsider standpoint, in terms of not being an OD. If you were the parent in that situation, and the doctor turned around and said, hey, we've got this treatment called myopia management, and you've never heard of it before. Because for a lot of parents, they are hearing about this for the first time. So maybe curious on both your perspectives, how would you feel about that, and how would you respond to it?
Well, I think first, the natural inclination is maybe one of anxiety, right? You're saying something about my child that is either going to happen or is happening. So I think that would be the first reaction. So I think having the OD be sympathetic to that when they're sharing this information. But then it's about information, right? And so I hear successful doctors sort of have that first conversation, then send home with materials, or you do the dreaded Google searches or whatever, right? But you find out more information. And then I think the follow-up conversation is probably really important. And then I think, the other barriers that I think of as a parent is, it is sort of an investment into the child's health. And so that should be, I think, pretty high on a person's list. And then you think, can my kid do this, right? And I think those are some of the elements. But I know we can talk about, all of us have kids and how proud we are of them because they're resilient and they can do much more than we think they can. And I think sometimes doctors, well, Johnny or Susie can't put contact lenses in. So those are some of the thoughts as a parent. But, as a parent and an OD, what do you think?
Kids do hard things.
Kids
That's been a theme. That it's interesting that you brought that up because I don't know if every parent feels that way. We love our kids and we like to think we have 100% confidence in them with everything, but we really don't all the time. And sometimes with contact lenses, because I used to hear it all the time, I don't think he or she is ready for contacts. So how do we respond to that?
Yeah. Or for some reason, all the hard things they do outside of contact lenses lives here, but contact lenses is that much more harder, which is not so fair, perhaps. I've had doctors share with me if kids can tie their shoelaces, they're ready because it takes a lot of finger coordination.
That's a good one, yeah.
Or, my kids definitely went from Duplo to Legos for really complex blocks and building these gigantic structures. Magnetiles, as well are very popular amongst kids these days. But I know, at least for my kids, they started piano at age 5, and it's about putting your fingers in the right place and for sure eyelids and, getting that lens closer. That fine motor, they can kind of actually do fairly well. And it's been studied as well, and we hear the real life stories, but it's good to have both sides of that. Every day we see kids doing hard things.
Well, and they get excited too, right? You hear stories of, you're not wearing the glasses playing soccer. And so you actually, the child knows that they can start to do hard things. I love the music analogy because I'm sure they weren't really good when they first started, right? And then, and it's probably the same when doctors, start myopia, right? They're not going to be great at it right out of the gate. The conversations are not going to be perfect, but
correct.
But I think like most things in life, you got to take that first step because if you don't, we can all put the barriers up. Well, it's too expensive, or the parents aren't going to get behind it. And 2 years go by, and you've just had all those kids that you referenced coming through that are not getting the care that they really deserve.
Yeah. And I think we're almost at that tipping point where, maybe not a popular take, but I think ODs and ophthalmologists as well might feel a little bit like I can't sleep too well at night if I didn't at least offer it, prescribe it. And they can always say no, but at least I did my part. And I didn't wonder if I did all that I could have. So I think we're getting close to that point.
You said something before. Actually, we had this conversation we were discussing the obstacles that, or some of the maybe resistance that parents would have. And we talked about how a lot of times it might be the first time that they're hearing about myopia management when they're in the chair. So there's always going to be some apprehension about something we're hearing about for the first time. But you brought up a good point where parents hear all the time about things for the first time when they go to their doctor. Why is this different than that?
Because I think at least parents that have myopia, they knew what the process was like in their childhood. And parents that have young children, they actually may have grown up only knowing daily disposables and knowing that number went up every year and what's the big deal? Maybe the parents had LASIK and they're like, I'm a -6, nothing's wrong. And they don't fully grasp that part. But like you said, Steve, I think patients come into the practice, I'm hearing about cataracts for the first time. I'm hearing about computer progressives for the first time. But myopia is so ingrained in this just rhythm of correction, improve or changing that correction once a year that they can't wrap their head about this eye stretching longer and weakening the tissue back there. That's just totally out in left field because I think of 100 years of history, of just increasing prescriptions.
Yeah. Without that being an option for so long, it almost feels like myopia has been normalized.
Yes.
Well, I'm just unlucky if I have a -6, if I have a -8 prescription, but I don't, and maybe that's one of the issues that create some resistance to seek treatment is that people don't see it as a disease. And putting thought into that message to get people to understand that it is a disease, it is something that's preventable and it doesn't have to be normal. I think if we could somehow change that narrative, and it might take some time, but if we could change that narrative, then I think people might approach this treatment option differently.
Yeah, the National Academies of Science recently put out a nearly 400-page report with that specific conclusion that myopia fits the definition of a disease and it ought to be taken head on. And I love the multidisciplinary kind of collaboration. It wasn't just ODs and OMDs, it was the sciences and public health and everybody kind of working together on this report. So year after year, there's this more authority papers, if you will, that like we got to do this as standard of care.
I like to put myself sometimes in the position of the parent, the position of the patient. So I'm going to go back to you and your background as a parent. How would you like to be approached? I think we talked before about what some of your apprehension, but again, you take your daughter in and then this is recommended as a treatment. As a father, how would you like that conversation to go in a way that's going to get you to at least lean into it? I know we're not always getting the patient to agree on the spot, but really have genuine curiosity and interest in wanting to know more about this, and then hopefully seeking to actually move forward with this treatment.
Yeah. I love what you said. It's a disease, but it's preventable. So I would like to be presented that there's a solution, right? So you picture you've gone in with your child and you've had the eye exam and you have the conversation with the doctor. That's where there is a solution, Dave. There is something that can be done here. There's a lot of science behind it. There's a tremendous product called MiSight, and it's a daily disposable contact lens, but twist it or make it be more about the outcomes can be and are proven to be positive. And in some ways, particularly if the doctor is faced into this, I really wish I had this when I was your child's age, right? I think that, and then you play a little bit on the emotion, but there are solutions to this. And then I think there's some truth has to be said as well, which again, I think Dr. Tybone talked about, was have the conversation to say, look, this is a big decision. I don't expect you to make it right here. So go home and talk to your spouse and talk to your kids about this or your kid and understand their motivations. And I think that conversation that ties it all in, and then we'll have a follow-up conversation. So I haven't tried to hard sell you in any way or me, but I've been given options to think about, to research, and then to say there is a solution. So to me, it's solution oriented. It's not, well, you have this problem and I'm going to get glasses and it's going to be fine. And I would probably talk a little innovative too. This is new. This has only been out for 3 or 4 years, but it has been studied in thousands of kids. I forget the number, but it's
2,300.
It's a lot of children, right? So that's the piece that, those are some of the things for me as a parent faced with this. And I think I would hope that ODs would find parents to be receptive to that approach.
They're really
lunch, brother. You guys want?
Yes, I wonder when you're going to offer it.